Hello and welcome to APPS Congress 2021. This is a special symposium, Children and COVID-19. My name is Suvikram Law. I'm a pediatric intensivist from Siraj Hospital, Thailand. It is my pleasure to introduce the speaker, Dr. Frank Lei Lu. Dr. Lu is the director of the Division of Pediatric Pulmonary and Critical Care Medicine, Department of Pediatrics, National Taiwan University Children's Hospital. He's also the director of this Center for Child Protection Medical Care, the convener of Child Friendly Healthcare Program, and Pediatric Integrated Care Team for Pediatric Palliative Care. Dr. Lu is a clinical assistant professor at the Department of Pediatrics, National Taiwan University Medical College. In this session, Dr. Lu will give a talk on the topic, Pediatric Resuscitation Concern in COVID-19 Pandemic. So welcome Dr. Frank Lei Lu.
Ladies and gentlemen, the next topic we're going to talk about is pediatric resuscitation concern in the COVID-19 pandemic. I am Dr. Frank Lu from National Taiwan University Children's Hospital. So when the child is suspected or confirmed with coronavirus infection, performing resuscitation is a rare condition. But if it has to be performed, then there are three important principles which has to be noted. The first one is the minimal staff principle. So only the medical staff who need direct medical care should come into contact with the patients infected with new coronavirus. The second one is using oxygen and respiratory support strategies need to prioritize the use of methods that do not cause aerosols and droplets. The third one is to evaluate the adequacy of resuscitation, consider whether it's necessary, how to perform it, and how long it will last. So for the recommendations and suggested practice and strategies, there's a couple of things we want to mention and talk about. The first is about the common principles. The first one is whether resuscitation is appropriate to perform or not. So it depends on the epidemic situation and the hospital capacity, the severity of the patient's condition. So we have to consider whether the resuscitation is effective and possible. So we have to have policies and according to the pandemic in the area, and we have to think whether the risk of performing resuscitation can really be affected to save lives or not. So the treatment options and the care plans has to be clearly discussed and communicate and set reasonable care goals. So the timing, whether they first arrive at the hospital and whether medical conditions deteriorate, then we have to set up goals. So if they just came to the hospital, we make sure the condition, set up the goals of medical care. Any advance directed, whether we're going to do palliative care, and we have to make sure that if before the deterioration, we need to anticipate and make advanced treatment. And so the third part is about the close monitoring. So we have to minimize the need for emergency intubation and the risk of the patient and medical staff being contaminated is also an important thing to keep a long run in the care for the patients. So infection control and precaution is very, very important. So if we know there's going to be a high risk of cardiac arrest, then the patient should move to a negative pressure ward in advance if possible to minimize the risk of possible exposure to the virus during the emergency process. And usually we suggest to close the door and prevent the virus from spreading through the air. And about ECMO CPR, it actually is not recommended for patients with new coronavirus infection, and there are still not enough empirical studies to confirm its effectiveness. So at the condition right now, it will have to be especially carefully consider whether to perform it or not, and not as a routine. So on the CPR side, actually, there's a couple of things which is very important we need to know. So I think DOM PPE is critical. and all medical staff must wear the current recommended PPE before entering the direct care sites. The second part is minimal contacts. So to reduce the exposure of medical staff and to keep the medical resources in the most effective needs. The third one is when we're doing handoff or changing to different teams, we have to make sure and talk about clearly about the virus status of the patients on hand. So this we can see, this is from Children's Healthcare Atlanta. They made a very nice poster for special considerations for resuscitation. So it started with donning the appropriate PPE, and inside the room how you're going to do. Outside the room there will be another team to support. So they have a nice positioning diagram here that you can say beside the bedroom. Beside the patient's bed, actually, there will be the respiratory therapists, nurses, the physicians, and the people doing the airway and chest compression. And outside the room, also a very nice team to support for the needs of the resuscitation in case this needed. And so for AHA and EUCOR, actually they published in Circulation 2020 about the changes using during the CPR. So the basic life support with the second rescuer actually has a similar process, but they have to make sure that you don the PPE and limit the personnel, which is the basic concepts throughout the resuscitation. And another thing is on this side box right here, that when you use the bag mask device, you have to remember to use a filter and a tight seal to decrease the droplets and aerosol coming out from the patient. For two or more rescuer, it's a similar condition. So and the other part of the BLS is all the same. For the pulse, the cardiac arrest part, actually it's very similar, but there's a couple of things you need to know. Of course, we still need to don the PPE and limit the personnel at the beginning before we start the CPR. And in the middle, which has a B box right here, is talking about prioritize intubation and resume CPR. So this part is very important. So sometimes we want to make sure that during intubation is as quick, fast, and safe as possible. So we need to stop the chest compression during intubation. And if the intubation is delayed, maybe we should think about LMA or other like bag mask devices with filter and tight seal. And whenever we can connect to a ventilator, we do that as early as possible. And another part is talking about the advanced airway. And so we want to use an advanced airway connected to a closed circuit with the ventilator, and minimize the closed circuit disconnection is very important. And and for the intubator, we want to use the person that's most experienced and skilled to has the first pass success the highest likelihood is much more important. And we can consider if we have the facility and the device, and we should use a video laryngoscope to do the assist intubation, which is will be more concerned and more helpful. And if the endotracheal tube can have a cuff, we suggest to use the cuff to decrease the aerosol and droplets. And UK also have their pulse resuscitation support, so they also have a similar content, which we have to use the PPE at the beginning, and we have to make sure that to talk about the COVID-19 status, which is very critical and important, and to make sure that decrease and to make sure that the patient needs to do the resuscitation. So for about the resuscitation skills, actually, we have talked about using the bag mask device. We need to use the filter. So HEPA filter is a very important part which can help to decrease the virus shedding or coming through the aerosol. And early intubation, we don't want emergency part. So if you in advance pre-see that intubation is needed, we will do it as early as possible, and performing the necessary support. It should be placed immediately and early. Then the regular case. And if there's a balloon, we need a cuff and use a HEPA filter and connect to the ventilator and respirator as early as possible. And so when usually we give oxygen before intubation, if you use a ambu bag mask device or T-piece, we always need to remember to put a HEPA filter in front of it. For larger patients, usually we will use a non-rebreathing mask with a surgical mask covering it outside to give the oxygen support through that way. And so endotracheal tube, just as mentioned, we want to use the person intubates needs to be the best experience and to first pass as possible and use a video assisted laryngoscope. And usually we'll stop the chest compressions to decrease the interference during the intubation. And just in case there's a difficulty or delay in intubation, we use all the equipment with HEPA filters. So we can use the laryngeal mask airway or ambu bagging or these parts. But always remember to use the HEPA filter connecting to it. And once you have intubated and connect the ventilator, always use a closed circuit and decrease the opening of the circuit as less as possible. We also need a HEPA filter, and we have to use the inline suction as possible. And the last part is talking about mechanical chest compression equipment. It has we can use it in adolescents, but the team needs to has the familiarity and experience to perform it, and also of course the device. And so there's a couple of things that we need to think about when we intubated the patient with ventilators, and there's a sudden cardiac arrest. So usually we sometimes will do the bagging, but we suggest during the COVID-19 pandemic, actually we continue to connect to the ventilator with the HEPA filter and keep the circuit closed. It's very, very important. So you will need to adjust the ventilator settings to allow the asynchronous ventilation during the chest compression, which is very important. So newborns can change to the time cycle setting, and so the ventilator will not be triggered by the chest compressions. And during the chest compression, we will suggest to increase the FiO2 to 100%. And give a low tidal volume goal. So that will be children 4 to 6 ml per kilo, and adults for 6 ml per kilo as a lung protection strategy. We'll turn off the trigger settings, and we'll set the number of breathings 10 minutes. 10 breaths per minute for older children and adults, and 30 breaths per minute for newborns. And so we will have to adjust whether adjust the PEEP, the alarm, and to ensure the endotracheal tube or tracheostomy tube is safely and firmly connected. And we don't want to accidental tube slippage, which will cause lots of the trouble and the issue. And so if there's a return of spontaneous circulation, we will adjust the settings according to the patient's condition at that time. And we all know, especially in adults, the prone position will help with the respiratory condition of the patient. So in case we are doing a prone positioning and then happen a cardiac arrest, there are some things we need to think about. So the first thing is, if you cannot make sure the airway is secure at that time, then we need to change the position to supine to give a secure airway first. So if the airway is already secure and the patient maintaining the prone position, we can try to do that resuscitation during prone, but actually the effectiveness is unknown. But we have to make sure that, because if you shift the patient's position, you have to make sure the airway is still kept and there's no risk. So if we want to do a prone position, usually we put our hands at the T7 to T10 position and and also with the shock, DC shock, we'll do a front chest and back position during electric shock. For the newborns, we should have a skilled medical staff around, and we have to make sure and be very careful because the mother may be a potential source of aerosol infections encountered by the neonatal medical team. And the management and initial steps for the newborn care is actually the same, but we have to make careful that we don't do routine suction, we do not administration any drugs through the trachea, and we use a closed incubator to transfer the baby and to care for the baby. But have to be careful that closed incubator doesn't guarantee the transmission of aerosols will be prevented. But it's safe and better to have another protection through that. And about the post resuscitation management, if the condition is out of hospital resuscitation and the pandemic is very severe and there's a very low probability of survival, and additional risk to transport the process and send the patients with to the hospital with the hospital staff increasing the risk, then we will suggest not to do the transfer at that time. And and another thing to have to be careful that the family and other contacts of the patient may be with a suspected or confirmed coronavirus infection should not take the ambulance together to decrease the transmission and infection rate during that part. So for a quick conclusion, we will have to have minimal staff contacts, personnel to involve in the patient care. We have to don the PPE, use the HEPA filter anytime using a positive pressure, and use a closed circuit with a ventilator support. The ventilator setting has to be adjusted during the chest compressions, and have to be careful about newborn resuscitations, and have to have clean and clear handoff communications between different teams. So so these are some of the references I think very helpful. So CHOP, the Children's Hospital of Philadelphia, they have a very nice web site that you can do reference, and I encourage all the people that are interested can look over there. And the circulation has the EUCOR and HA paper talking about the special things to do during the COVID-19 patient care. The European Resuscitation Council and UK also have their rules. And the Pediatric Critical Care Medicine in 2020 actually has a paper talking about the pediatric resuscitation practices during the coronavirus disease 2019 pandemic, what actually people do. And you can look at it if you're interested. Thank you for attention.